Women's brains need to be saturated in estrogen. They need to be floating in estrogen. This is really where women are satiated, that they're not begging for more, that they feel at peace. Their brain is working. They feel alive and vibrant, and they have energy, organic energy, where they pop out of bed and they're ready to take on their day without dragging their knuckles on the floor to the coffee maker. I don't think it will be long until women realize that these low dose therapies that they will now be prescribed happily from their doctors, they will stop working. And so I think women need to understand that they're not stuck in this second generation estrogen starvation. Hello, everyone. You're listening to the MeNoPause Moxie Podcast, where we strategically challenge the status quo on perimenopause, menopause, and female hormone balancing. I'm your host, Marie Hoig, and I'm here with my brilliant producer and co-host, Maggie Kuhn. Welcome to the show. Today, we're talking about the 4 generations of HRT and their clinical track records. Hello, Maggie. How are you?
I'm doing well, Marie. I think that women are going to really be interested to hear what you have to say about this idea of the 4 generations of HRT.
Yeah, it's something I felt I had to clarify years ago when I was explaining hormone therapy to women because they were confused on what exactly I was talking about. There's so many confusing aspects to female hormone balancing and a lot of misinformation. So I'm here really to clarify the differences so that women can make decisions based off of what they know they can get from each HRT system. I remember being at an A4M conference and a woman was talking about her hormone therapy and how much she liked it. And she's, oh, I'm on the best hormone therapy. I go to the best hormone doctor. But yet just a few minutes before, she was telling me about her headaches and her hot flashes. And I said, well, what hormone therapy are you taking? And she told me that she was on oral estrogen. And I was like, oh my gosh. And I meant to say it in my head, but I verbalized it and I said, well, you're not on the good stuff. And she was really offended by that. She goes, well, what do you mean? I said, well, there's different types of HRT and they have different clinical goals and outcomes, and some work for a while and some stop working. And so that's why I knew that I had to differentiate it, especially when I'm talking to patients who are coming in to find out what we're able to do for them, hormonally speaking. What I did was I broke down each generation and I put it in a bit of a slideshow that I'll share here so that we can get some clarity.
That'd be great because there is so much confusion. And I know for myself, I didn't know that there were different generations of HRT until I met you. I thought it was all the same thing. Either you're on or you're not on.
Yeah, as part of my job as a clinical hormone coach, I would meet with a patient that a doctor referred to me to explain what we offered. And if they wanted to stay under the realm of their insurance, well, they only covered like the first and second generation HRT. But what the patient was asking for clinically with those results, I had to explain to them that what their insurance covered didn't give them the clinical results that they were looking for. And so this is how I broke this down. It's not like the generations of HRT is a thing that everybody knows about. It's just a term I use to explain the differences. But I mean, don't try to go look up the 4 generations because it's not something that you'll find. But it's something that women need to know the differences in all of them. One thing I want to let the listeners know, HRT for physicians is really a tool. It is a clinical tool that the doctor you prescribe to patient to achieve the clinical goals the patient is requesting. So if a woman wants to just alleviate most of her symptoms, like to eliminate hot flashes or to reduce hot flashes, she would use one protocol. If a woman never wants to have a hot flash again, well, she would use a different protocol. So you have to look at HRT as an arsenal. And for those physicians that are listening, this will help clarify what's actually available for you as a clinical tool for your patients. So HRT really is an arsenal of tools. And there are 4 generations, as I explained. There's no real generations, but this will give you an idea and how I break it down so that you can decide which one is a good HRT system for you or why the HRT system you're taking is not working. First generation HRT is the old school stuff. They are oral, usually oral compounds. They are synthetic. They can be birth control. A lot of doctors use birth control pills as hormone therapy. In fact, that's one of the red flags you would consider in hiring your HRT doctors if they use oral estrogens or not. These protocols are prescribed at the lowest dose for the shortest amount of time. And a lot of the institutions that offer HRT training use this protocol. I'm shocked that there are still institutions that are training doctors on this protocol still as the standard. Not only that, the Menopause Society discusses these hormones, like such as Premarin, Prempro, the birth control pill, and is using this as the gold standard. The big problem with this protocol is because it's the lowest dose, it stops working in about 6 to 9 months, maybe 3 to 6 months for some women. But it doesn't really do the trick for long periods of time because the woman's brain and body require more estrogen than what these HRT protocols yield. So if your doctor is prescribing Prempro, Biest, Triest, Premarin, oral contraceptives, you're not really getting hormones. You're getting hormone-like products that are designed to shut down your own hormone production, but it leaves women estrogen starved. And this is what really confused us in the clinic when we were told, these are the hormones that you prescribe to patients. But yet patients were coming back in a few months saying, can I have more? Can I have more? But the standards are to keep them low and then get the patient off of them as quickly as possible.
Well, no wonder there's so much confusion and frustration for both women and doctors, right? Because if this is what a doctor was taught to use and this is what they're using, and then it works for a while and then doesn't, and then they've got a frustrated patient, it's a losing situation that everybody's been set up with this one.
Certainly. And even doctors get frustrated because the patients are asking for more and they're like, hey, you're on the max dose. And the doctors, there are many, many doctors that don't educate themselves on estrogen. They just open up one of these packages, open up the package insert, and read down to the dosing instruction area, and they'll say, okay, this is how you take it. For a lot of doctors, this is the extent of the education they have. And this does not serve women very well at all. And there are so many other ways that you can take HRT to get better clinical results. However, if this is all a woman has access to, then take it. There are
I was
just
just
better
going to
ways.
say,
Yeah, if this is all, like some women in other countries, this is all they have. We never use birth control pills for hormone therapy. And that is one of the red flags for women to consider. If the doctor's telling you that they're going to prescribe birth control pills and call it hormone therapy, what this does is put women into chemical menopause because these are not really hormones. They are hormone mimickers that tells the brain a woman has enough estrogen, so it shuts down her own estrogen production. So this truly does leave a woman estrogen starved. So it suppresses the FSH and it lowers the estrogen. So if you look at these symptoms, the side effects of these, well, the side effects of these are, well, all the symptoms of menopause.
Wow.
And women don't realize that they're put on these chemical compounds designed to shut down their own ovaries. And young women are put, when they have irregular menstrual cycles, this is the go-to protocol that doctors put these women on. Well, if you have horrible periods, let me put you on birth control pills, but that is always accompanied by antidepressants, because one of the biggest side effects of birth control pills in reality of menopause is depression, anxiety, insomnia, mood swings. So this is so old school that we just don't use it. However, this is what insurance companies will cover. This chart was adapted from the STRAW 10 Stages of Reproductive Aging conference, where it gives you an idea about the 10 stages of a woman's reproductive lifespan. And this type of HRT approach keeps a woman's estrogen tank empty. It's designed to manage the symptoms of hormone deficiency, but it's extremely short-lived because of how deficient it makes a woman feel. And it always does need to be accompanied by psychotropic drugs. mood stabilizers, antidepressants, because women will experience the side effects of hormone deficiency or slash menopause. So, and this is, there's just so many better ways to do this. And I was on that first generation. That's what they put me on at 17 when I had horrible periods. And I lived many years on this in a state of chemical menopause, and I didn't realize I was in menopause. So I really spent the majority of my life hormonally deficient because of this HRT system I was put on.
Mm.
Second generation HRT are the is similar in that the recommendation is the lowest dose for the shortest amount of time. Now, these are the protocols that they teach at the American Academy of Anti-Aging Medicine and the Institute for Functional Medicine. They are
Mhm.
the patches, creams, transdermal creams, compounded creams, and also pellet therapy. Have you ever been on this type of
Oh, yeah. I
program?
was just going to say, this is the type of hormone replacement therapy that I was on. And like I said, I thought I was on hormone replacement therapy, and I was. I just didn't realize that I was on this lowest dose, shortest amount of time, and at these with these mechanisms. Some of it was oral, some of it was patch, some of it was cream at different times.
Well, when we were first starting to use these, we really thought that we had scored, like, oh, because these are really uh but these are also static dose, and I'll get into what static dose is. Well, static dose is taking the same dose every day. And this is what they teach at the American Academy of Anti-Aging Medicine, where most prescribing practitioners get their education along with the Institute for Functional Medicine. And this is their gold standard. These are bioidenticals, and this is a real selling point with this generation. It is the most common prescribed, but it too stops working in a matter of months because it's just not enough. And we had frustrations with these because we found we thought that these were it when we learned this. So we started putting all of our patients on this protocol, and when we're like, oh my gosh, we just love these bioidentical hormones, and we liked them too because we just thought they were the best thing. And we were trying to get to that lowest dose possible because it was at this time they were still telling doctors, be careful. We don't know. Estrogen causes cancer. So we'd ask questions like, well, then what's the lowest dose? We don't want to give anybody cancer. So what's the lowest dose? How high can we go with this? But they didn't really give us any answers. They just said, well, just start low and go slow. But we really never got the answers when I would ask, listen, what's the lowest maximum dose? And you say go slow, but how slow? Like, how do we titrate this dose? Our patients are asking for more. How do we, increase those dosages? And what do we do when we get to the maximum dose of that patch?
Right.
Patients are asking for more.
Right. And of course, my experience was not only am I not going to get more, but we're going to get you off of this.
It's just that fear. It's like, well, yeah, we're going to raise you up and give you what you want. You're going to feel good. Then you're not going to feel good again. And then because you're telling me you're not feeling good, I'm going to take you off because I think it causes cancer. And I don't want to be the one to give a patient cancer. And so this is the mindset and why women like you and millions of other women suffer on this type of protocol.
The good news is that the FDA just had that expert panel in which they announced that there is no proof that estrogen causes cancer. There's no
Yeah.
direct tie, and they're looking at removing that black box warning. Isn't that correct?
It is correct. And but they're just still in this mindset of low dose.
Mm-hmm.
They're not, and when the medical society, when they team up with the FDA, they're going to say, okay, they're only going to recommend the first and second generation HRT.
Hmm.
But it stops working because the brains and bodies of women require more than what these protocols yield. So when I'd go back to the conferences and say, okay, we've maxed out, what do we tell these women who are asking for more? Is there a way we can increase this dose? And they just said, no, this is where you are. And then we say, okay, so what do you do? So I started interviewing doctors when I go to these conferences and say, well, what do you do? What do you recommend? Oh, well, this is where we actually make our money is we sell supplements.
Hmm.
They sell supplements instead of prescribing drugs to manage the symptoms that these women still have on these low dose protocols. And
Hmm.
this is really my concern with this whole movement with HRT is safe. Well, if HRT is safe, why are you telling us still to use these oral contraception and these low dose protocols. So there's no real standard on what that dose should be or how high those levels should be, because even second generation HRT protocols really only give women enough estrogen. I think the maximum levels women can get with their estrogen is around 150s, 125, 150. But
Mhm.
that's just low. It just stops working. Women need much more circulating estrogen level than 150.
Well, and I'm sure that's probably a shock for some women to hear, because that was the big eye opener for me. Was I was sort of looking around, because I had started to hear some rumblings a while ago that there might be something other than this second generation, but I didn't know exactly what that was. And I started kind of poking around, doing some research, and I ended up in a forum and I saw a woman post that she was in her 70s and her estrogen had hit 250, and she was like, I feel great, ladies, don't give up. And I thought, 250? I'm at like 40 and my doctor's trying to get me lower. That was the first I'd ever heard that you could go so high.
Well, and then people consider that high. And when people say, oh, that's high, I'm like, okay, based off of what?
Yeah.
Based off of what? Has this been your clinical experience? Have you read studies that indicate that's too high? Like, why are you so fearful of this? Even doctors are fearful of this. It's like, oh, well, that's high dose. I'm like, how do you figure? Well, it's high dose if you're only a low dose prescriber, but it's not high dose to a woman who has plenty of it. She would call it, that's pretty close dose. It's not, still not the optimal level that we know that women do best. But I tell you, when we transferred patients from first generation HRT to second generation, it really was like an awakening. And we were like, oh my
Mhm.
gosh, this is better. They're bioidentical. Um, we have transdermal compounds, so patients don't have to just use the patches, because the patches have their own problems with coming off and absorbability. And the technology wasn't very good back then either, 15 years ago when we were starting to bring this on. But then we had this whole wave, because this has happened in waves. We transferring patients protocols. Now we're having a wave in 6 to 9 months again with women asking for more estrogen, and we've maxed out on these dosages.
Mm.
And so what do we do? So I go back to the conferences and I'd ask them, what do you do? Like these experts, I'd wait in line and ask my questions after the lectures. And I'd say, okay, well, what dose do you recommend? And if you're taking blood levels, at what level are you finding that patients do well with, that they're not asking for more?
Hmm.
And nobody has ever given me a straight answer on that. And they usually end up, when they can't answer a direct question like that I ask them, they start asking me about my practice and if I'm a physician. And once they find out I'm not a physician, I'm just a clinical hormone coach, they feel entitled to not have to answer my question, and they
Hmm.
dismiss me or they escort me out of the auditorium. And this is part of the frustration, when I started interviewing doctors saying, well, what do you do when this
Right.
stops working? Well, that's where I make my money. I start selling supplements to manage the symptoms now. So I've got bioidentical hormones and I have a business model where I can make money managing the symptoms that still exist in these patients. And then I thought, oh, well, that's a good idea. So
Mm-hmm.
then I brought that business model to our practice when we got more trained in this and thought, okay, well, this is nice. So now we've got supplement sales here to help sustain the practice, but yet we still had a problem with patients. You can't manage the symptoms of estrogen deficiency with supplements. The only thing that can manage the symptoms of estrogen and other hormone deficiencies are the hormones.
And
So
that is that bears repeating. I'd like you to actually say that again, Marie.
you can't manage the symptoms of estrogen deficiency and progesterone deficiency with supplements or drugs, because you're not addressing the root cause. And that was my frustration with functional medicine. It's like, hold on a second, you guys claim to be an institute that teaches doctors how to address the root cause and fix the problems as naturally as possible. But if we were really addressing the root cause of hormone deficiencies in women, we wouldn't give them a low dose to keep them deficient and then make a bunch of money selling them supplements to manage the symptoms that the patients wouldn't have if you fully restored these hormones. So here in our education, still there was this fear, well, we don't know how high we can go. And I was like, why not? And this is around the time I started to do deep digging and research
Mhm.
because I couldn't find many studies on what levels, blood circulating levels of estrogen women did best. And I couldn't find many studies on second generation HRT at that time. So really what we were watching was the activity we were getting in the clinic, what women were talking about. And I started to realize that when women were at levels of 150 on first generation, they had similar conversations. They were saying the same thing. Oh, this fixed my hot flashes. Oh my gosh, my hot flashes are back. Can I have some more? Well, no, sorry, it's all you get. Then we put them on second generation and then they feel better. We can get those levels up a little bit more. Oh, my goodness, I feel good. I no longer have depression. Oh, wait, I have depression now.
Right.
And so it's like, okay, so they do and they don't, and they do and they don't. So, and then they're coming back and asking for more estrogen. And yet we were just like every other practitioner, oh, well, here, take this supplement, take this supplement. We're going to incorporate a psychotropic drug with this supplement. So now the patient is on this cocktail of low dose hormones, psychotropic drugs, and supplements. And the only people who are really making money here are the physicians and the pharmaceutical industry. And the
Right.
women were still suffering.
Well, and there was such a big deal when the concept of bioidentical hormones came out. At least that's my recollection. And that seemed to be the big revolution in care, was that we were moving away from synthetic to the bioidentical, and that therefore, it was supposedly safer, again, safer than what, but also better. And I suppose that it was, except that what I'm hearing you say is that for only a certain amount of time, and so many of us have experienced this, then it stops working, and then we're right back at the beginning, and it's somehow my fault as the patient that it's not working.
Yeah, and that's the universal hormone gaslighting. But the one thing with second generation HRT that I do have to say is that I think everybody can agree that a bioidentical hormone is better than a non-bioidentical hormone. And just a quick thumbnail sketch, a bioidentical hormone is a hormone that mimics the cellular structure of the hormone in our body, that our body produces. So the body is under the impression that the hormones that you take are your own. And usually those first generation orals, they do pass the liver, and so you never really know what you're going to get out of that after the hormone has passed through the liver. And we're able to bypass the liver with these transdermal creams and patches and low dose sprays and sublinguals. But again, we were only able to achieve probably close to about a 200 level of circulating estrogen with this. And that really, that worked for a while. And I was one of those. So as each generation that we were learning, and as I was learning in the clinic with coaching patients and then taking these hormones myself, I learned it's like, okay, I'm maxed out. Can I have some more? And I would ask the doctors, just give me some more. I want, if you don't want to give the other patient, give it to me. Let me take this risk. And that way you'll know, I know if it helps. And that's how I've done a lot of this, was increasing my dose under the care and the supervision. But not only that, monitoring my clinical indicators and my blood work. I mean, there were times
Mhm.
I monitored my blood work every day, with the exception of Sundays, for months at a time, so I can see how these protocols worked. But back to the second generation HRT, these protocols leave women estrogen starved, but they don't leave them in a postmenopausal state. It leaves them more in a perimenopausal state, in like a stage 2 or 3 perimenopausal state. So the estrogen tank is still empty, and the real business model here is the practitioner sells a bunch of supplements to manage the symptoms and to control the methylation pathways that wouldn't need to happen or wouldn't need to be managed if women got enough estrogen so the body can naturally methylate estrogen without having to take a bunch of supplements. But for a while, we were doing this protocol until, well, my goal was to get as much education on HRT as possible. And what's nice is I worked with a team of physicians that were so hungry to learn about this that we signed up for every single conference we can find. But we found that, okay, you guys are teaching the same thing. So then there was a point where we were like, okay, we think we're doing what everybody else does. We're getting the same results, and this is it. But there was still this cry from our patient base wanting more estrogen. And then somebody called on the phone and asked if we did the Wiley protocol,
Mm,
which is a third generation HRT system. So third generation HRT is what we consider like the next step up, which is they are typically compounded third generation protocols. They're compounded from a compounding pharmacy, usually with a very specific formula. And these two are bioidentical. And the more patients that were calling us asking about this protocol, we were like, oh, there's a protocol we don't know. Okay, we need to know about this. What is this protocol? Where did you get it? And so I started calling the doctors that were prescribing this and found out who formulated this protocol, which is T.S. Wiley. So then we contacted her and said, okay, we need to know everything about this protocol. So then we educated ourselves on this. And of course, with me being this, okay, let me see. I want to see for myself. So then I started on this protocol, and oh my gosh, this particular protocol, I have to say that this was a true eye-opening experience. And I really believe that this protocol saved my life because
wow.
of the levels of estrogen, because I was so suicidal in my luteal phase. My estrogen was so low that my brain still wasn't working right, especially the closer I got to my period or in that phase. But what was nice about this protocol is I got more estrogen. So we would consider this a more moderately dose. It's not low dose, but it's not
Right.
adequate dose either. It's a moderate dose. So I went from, the symptoms management to let's give you some that your brain is working for just at least a little while until your body sucks up that dose and maxes out on that dose, then you'll go back to feeling like you can't think at all. And then to going on this protocol. But the beauty of this protocol that we didn't realize was so beneficial for women is I got my menstrual cycle back in a way that I didn't have PMS or PMDD or the mood swings. But there's so many clinical challenges to this protocol that doctors really throw this protocol in the garbage. They're just like, I can't take it, because the education that's given is so limited, and only Wiley gives the education on this. There is one or two other institutions that offer third generation HRT training, but they still haven't fixed the clinical challenges. I call them flaws. The doctors are like, you can't call them flaws because it's still a good protocol. They're challenges. But if a doctor can't figure out what these challenges are or fix them, they're flaws to me as a patient.
So, like, what are you talking about? What are some of the flaws in this
So this
protocol?
protocol is what's considered a physiological protocol. What this means is it's rhythmically administered on a dosing schedule that the patient takes these hormones in a rhythm. So if you look at this graph here, this is the natural 28-day cycle of the rhythms of the hormones that we produce. Estrogen has its own hormone tide cycle, progesterone has its own hormone tide cycle, and testosterone and thyroid, our hormones have their own cycles. And so a woman has a 28-day cycle, as men's bodies function on a 31-day solar cycle. Women's bodies function on a 28-day lunar cycle. So that these hormones are administered in a way that the patient takes a baseline dose for about 6 days, and then the dosing increases for a few days, and then there's another titration up so that the patient is mimicking this natural physiological cycle. So this is physiological dosing. That
Right.
term physiological is used in a couple different ways. Some doctors use the term physiological dosing, mean we're going to bring your levels up to a reproductive physiological state. But I believe the physiological is really matching the natural physiology of the hormone.
I
The
would imagine there's a lot of room for human error in that in this protocol.
It is so difficult to figure out. And actually, our clinic was the clinic that wrote the most. We had the most patients on this protocol than any other physician on the globe. And we were determined to figure it out because it was just brilliant that you can actually restore a healthy menstrual cycle in women. So, and this was a real eye opening. And this started to open my eyes to the whole delaying menopause and the menopause prevention. But it, you have to get the estrogen up high enough here to trigger a G1 arrest, to trigger receptors, not only for estrogen, but for the other hormones the body's anticipating in the luteal phase, such as progesterone. If this dose doesn't get high enough, then the patient doesn't produce enough receptors for progesterone in the luteal phase. So women end up having these horrible luteal phase experiences
Mm.
because the estrogen peak in the follicular phase doesn't get high enough or for long enough, because the peak here around day 12 on the Wiley protocol is only a few hours. I could say about 24 hours, and then it drops off to
Hey, this is my moment. This is when I feel good.
that 1 or 2 days a month. But
Right.
then there's this stark drop down to an all-time low, day 18, and this is horrible for women
Right.
because they were just feeling good here, and then 5 days later they are crashing to their all-time monthly low. And now this is where our phones are ringing off the hook. And as a
Mm.
coach, I'm on the phone. So all day long I'm on the phone with every woman in their luteal phase. I've been like, okay, what day of your cycle are you? Okay, luteal phase. I'm like, okay, how can we fix this luteal phase problem? So then we started to tweak the doses. Well, maybe we shouldn't drop down so low here in the luteal phase at day 18. But then once we started to manipulate these dosages, we found that we didn't get this rhythmic triggering, this rhythmic protocol, that these peaks flattened out.
Mm.
And so now we were no longer doing the protocol.
Okay.
But what we did discover in this is that there is never a day in a woman's life where she feels good when she doesn't have plenty of estrogen.
Mm.
Yes, this protocol appears brilliant. And it was really such a great protocol when this is all we had. This was like the most advanced.
Yeah, this was considered, I think, pretty out there in its time.
Oh, yes. But this is what Suzanne Summers was using, and
Yeah.
she got bashed, and she wrote about this in her books, in her earlier books. And this is what really instigated her desire to want to write about hormones, is really when she was coming across this particular protocol. And I thought it was wonderful too, except for in my luteal phase.
Yeah. I
And
remember reading that book many years ago, and I was both fascinated and in awe, and admittedly thought she was a little nuts. And yet it really intrigued me, and that thought never left me, even though I didn't know how to find a doctor who was doing something like that. And actually, eventually, I thought I was doing a similar protocol. I thought I was on I thought all hormone replacement therapy was the same.
yeah,
So once I was on, I thought I was on. Didn't realize I wasn't doing this full rhythmic administration, the Wiley protocol, but it sure piqued my interest, and it kept me open, I think, to new ideas later in life.
yeah, and it really opened our eyes to there's something to this, but like this protocol, there's about 20 to 25% of women where this protocol works.
That's pretty
And when we went back
low.
to Wiley, I know. Well, and so this is the frustration with physicians is they go to
Sure.
Wiley for the training, and she recommends you have to do it this way. And if you don't do it this way, I'll sue you for patent infringement. So that makes it kind of tough for the doctors to work with her, because that's kind of her mentality. This is how it works and you need to do it. And if it's not working, then it's your fault, doctor. And so the doctors are getting blamed for why this isn't working. And the doctors are like, I'm coming to you for answers. You're not giving me answers. You're just blaming me. And the patients are suffering. So guess what? I'm not going to do this protocol. And so then they get their patients off it. This is why there aren't a whole lot of practitioners doing the Wiley protocol, for the lack of training and lack of support. Or there are some doctors who said, this protocol is brilliant. I'm going to try to figure this out to the next level. If you're not going to help me with this, then I'm going to try to figure it out on my own. And these are the practitioners that women need to seek out, because these are the doctors that step outside of the box saying, okay, there's something to this. There's something to adequate dose, because here we were able to get levels with this Wiley protocol around 200, 250. I mean, it is really, we found that it's the estrogen that makes the woman feel good. And when they crash in the luteal phase, they don't feel good.
Mm-hmm.
And so what are we supposed to do? And when we keep that estrogen level up, then, then you kind of mess up the entire protocol. But what was nice about this is you can regulate a woman's menstrual cycle with this. Like with me, I'd never had a healthy menstrual cycle. And for the first time in my life, I was able to recreate one and depend on one. But I too had flaws with it, because I was a horrible patient. I had a horrible diet and lifestyle. I was one of those women that just said, oh, just give me the hormones. I don't want to change my diet. I don't want to work out. I don't want to just give me the hormones. And let's just see what I get from that. And course, I caused my own problems with that until I, figured out that diet and lifestyle do influence hormone replacement therapy. So
Which we'll be
this is,
talking about at another time.
oh yeah, we'll talk about that another time, because hormones alone don't work to the fullest capacity. You can really get on an advanced HRT system, but if you don't have a diet and a lifestyle to support it, then you won't get the full benefits of it. You could take it to the next level, but because one, I had a poor diet and lifestyle, and I brought this on, but I felt better than I ever had in my life, even though I was having some negative clinical indicators with this protocol, because I had a high sugar diet and a high simple carb diet, and severe gut dysbiosis. And women with severe gut dysbiosis cannot take protocols like this, because women with gut dysbiosis tend to store a lot of estrogen in their tissues and their fat, and it will make them fatter in the beginning, and they freak out, and then they stop taking the protocol as prescribed, and it turns into a mess, and they're like, I can't take it, and then they get off of it, and then we put them back on second generation.
Wow, that is definitely going to need to be a future podcast episode as well, because I hear so much from women about the weight gain. And so we'll table that for now, but that's a really important one for us to circle back around to.
Oh
And the
yeah,
gut dysbiosis is a very interesting component to that.
it really is. But then we also learn that estrogen influences gut dysbiosis, and so we'll talk about that in that podcast as well. So this particular protocol is the Wiley protocol, but there are some practitioners who created their own protocols as they worked with compounding pharmacists to fix those flaws. So there's some independent type of third generation HRT that some doctors still use to this day. There's very little training and education, but the education that's given includes the clinical flaws the doctor still needs to work around, and then supplements are sold to manage these clinical flaws. And there are just many clinical challenges. But with this particular protocol, it doesn't leave a woman estrogen starved, but it does leave her estrogen hungry.
Mm-hmm.
It does put her in a state like a pre-perimenopausal state, like in the beginning of a transition, almost in a stage 1 perimenopause, where women, they have more estrogen and they feel good, but yet in the luteal phase, they just feel really lethargic and depressed and sensitive and tearful and moody and with PMS. And, and it's just,
All
it's,
things that we were told that we just needed to accept because that was part of being a woman.
mhm. Yes. And so it was almost like, in one of our physician meetings, I said, so if we're going to do this protocol, I have to be honest with the patient with their experience with this, because as part of my job is to explain what the patients are going to experience on these protocols. So then I was like, so now I have to tell the patient, well, you're going to feel good for 2 weeks. It's better than not feeling good at all ever. It's almost like 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. And I was experiencing this and having my own, but at the same time, we were working with the hormone replacement therapy I was taking and realized that, maybe there's a better way. And
Mm,
then that's really where we came up on the fourth generation HRT, which is what we believe truly is the gold standard for female hormone replacement therapy, and what every physician should be taught how to use. And because this has been derived from all these generations, what worked and what didn't work, tweak this, adjust this, monitor clinical indicators, monitor lab work timely. And so fourth generation HRT is really fixing the flaws of all the three generations and giving women enough of the right hormones at the right time and in the right way. And these can be compounded depending on the hormones.
mhm,
They can be injectable, they can be oral, depending on the hormone. Um,
mhm.
but the goal for fourth generation HRT is for full restoration, not just giving a woman a quart of a tank, half a tank, three-quarters of a tank. This is full restoration where a woman doesn't feel like she needs any more estrogen. And this is really how we knew women needed estrogen or not, is when they asked for it. Like
Mhm.
women would say, oh, I'm on this. Okay, oh yeah, your labs are at, your estrogen is at 200 or 250. Oh, that's great. Yeah, but can you just give me some more? Can I just get a little bit more estrogen? And we're like, "Oh," and I was in that same boat too. It's saying, okay, well, yeah, what would it be like if I got a little more? How do we know how much more to give women? Like,
Right.
what is this maximum dose? And these are questions we were asking in the clinic and asking at the conferences and not getting any answers because everybody's still on first and second generation HRT,
Right. Right.
still to this day at the American Academy of Anti-Aging Medicine.
We're so lucky to have you doing, this trial and error on yourself
I tell
and
you,
really monitoring things to show us the way on this.
well, I tell you, I've really been put through the ringer. I have gotten fat, I've had acne, I've lost my hair. I mean, it's been up and down trying to figure out, what is this dose and how do you titrate this dose? And so we thought, well, women feel good when they're around 200, but they still have negative clinical indicators because we were monitoring. We closely monitor 50 clinical indicators in real time with blood work. So we know that estrogen works in real time with how a woman feels. So when a woman was crashing, we would have them go get their blood drawn and check to see what their estrogen levels are. And then pretty soon we were like, okay, so if you're having meltdowns on the kitchen floor, chances are your estrogen's in the double digits. And then that is almost like clockwork. And
Mm,
so we were able to tell by a woman's mood pretty close to what her estrogen levels were. This is how
wow.
accurate estrogen is with monitoring clinical indicators. And then so when I started messing around with my dosages, we came up to a point where I didn't feel like I needed any more estrogen. And
Hmm.
then we were monitoring blood work and realized, hey, there's a certain level here where, and then we were watching in the clinic where patients stopped begging for estrogen. And that really is a thing, that patients were begging for more estrogen. And then there was a point where they stopped asking and we'd say, okay, how do you feel? Well, your negative clinical indicator score is suppressed really low. Your estrogen is in this range. And all the other hundreds and thousands of women who are on this protocol are in this range and their negative symptoms are almost gone. And then the question was, well, what if we give them a little bit more?
Mm.
And then the doctors, well, like the patients aren't asking for any more, so I don't feel comfortable giving them any more. I'm like, well, then give me more. I want to see, will I feel better? Because I feel better than I ever have in my life. But I've said that at every dosing adjustment because, and then I felt like really I could not imagine feeling any better. And the majority of our patients were saying the same thing. And then I said, well, just give me a little bit more and let me see. I want to see for myself. You don't have to do it for anybody else, but just let me see.
Then what happened?
I felt like I had no estrogen at all.
Really?
I started to get negative clinical indicators, um, crying spells, headaches. brain fog. Headaches were different. I got different headaches. Like the headaches, my estrogen deficiency headaches were like my frontal lobe, my temporal, the base of my neck, and I was getting migraines. When I had too much estrogen, the brain fog was a little different. And my headaches were like my entire scalp. It felt like a bathing cap that's on way too tight. And then when I was monitoring my clinical indicators and blood work, and I saw it was kind of my estrogen was kind of in the higher range than what the other women were saying, and where I was feeling good. And I was on this for about 4 months and just, thinking that it might get better, but it didn't. And
Mm.
so at my next follow up, when I measured my clinical indicators and blood work, estrogen seemed like it was higher, but then my negative clinical indicator score got high.
Hmm.
So I said, okay, well, then let's bump my dose down to where I was when I felt good and my clinical indicator score was suppressed. And then this is really how we figured out what that hormone sweet spot is where women do best. There is such thing as too much. There's such thing
Interesting.
as too little. And this is why I talk about the Goldilocks
Yes. I've heard you
of
say that, Goldilocks.
it is just, there's just right. And it's adequate dosing where other oh, that's high dose. You can't do high dose. Like, okay, really, what's high dose? You do low dose. So anything more than low dose is going to be high dose to you. What experience have you had with high dose and what has been the clinical responses for? Well, I don't know, but it seems high. I don't use that because it's too high. I'm like, based off of what? And this is really, so the information that I get is really based off of what I've been taking and working with thousands of women over the years who are crying for more estrogen, and we gave them enough until they stopped crying for it.
Right.
So what we found here was this was the most effective. Not only was it the most effective, it was the most sustainable. This is the first sustainable protocol we've come across.
Mm-hmm.
And so this is what we found out, that women's brains need to be saturated in estrogen. They need to be floating in estrogen. This is really where women are satiated, that they're
Mm.
not begging for more, that they feel at peace. Their brain is working. They feel alive and vibrant, and they have energy, organic energy, where they pop out of bed and they're ready to take on their day without dragging their knuckles on the floor to the coffee maker. And the things that they're able to cope, the coping mechanism, the self-reliance. I was shocked that I was able to depend on my mood absolutely every single day. Like
Mm.
I have to say that this was the protocol that I for the first time felt what it felt like to actually be happy. I
Wow.
thought I knew what that was until I got enough estrogen. I thought, and I had maybe glimpses of it over my life when I've had moments like with loved ones or, vacations and stuff where I didn't have to worry about anything. And oh, this is so nice. But it's interesting, when I lived my entire life hormonally deficient with mood swings and anger outbursts and horrible menstrual cycles. No more horrible menstrual cycles. In fact, not only, and no PMS, no PMDD. And it's like, and my biggest complaint was I started my period without even really knowing it,
Mm.
because I was so used to having such severe PMS that I knew my period was coming. I didn't have any pelvic inflammation, no mood swings, no anger outbursts, no outrageous behavior. My reactions were proportionate to the situation at hand. And the chaos that was going on around me, that went on around me, I was like a rock. I was so emotionally stable.
Wow.
It was, it gave me a level of anxiety that I was talking to one of the doctors one day in the clinic when he passed me in the hall and he says, "Hey, how you doing on those hormones?" And I go, "Well, love these things, but how long is this going to last? Because the other protocols failed
Mm.
eventually." And they said, "Well, if you have enough estrogen, it won't fail you, and you'll have to get used to feeling like this." And I'm just like, so I have to get used to feeling good every day. Does this mean I'm going to feel good in 2 weeks next month because I want to go on a vacation? Do I have to plan my vacation around my period? I mean, it was just, oh no, you can be on vacation on your period. It'll be just like when you're not. You're only, you may not want to deal with your period on vacation. So you want to plan around that, but not mood wise.
Mm.
And
You
this
have
is,
said before, Marie, that estrogen is the master regulator for women.
yep, for
So I think
everything.
that's what you're talking about here.
Everything in the female body works right now because the brain has enough estrogen. Not only that, when women have enough estrogen, because as you know, and you've heard me say this before, that hormones are messengers.
Right.
And these messengers um, tell the brain and body really where a woman is in a reproductive lifespan. So
Hmm.
when women have plenty of estrogen, then their brains are working right. Their bodies are working right because the brain of the woman is under the impression she's in a reproductive prime and you have to be healthy for that. So the
Hmm.
muscle tone comes back, the joint pain goes away, the energy comes back, the libido comes back, the pheromonal exchange, the femininity, the sensuality, this hair, the skin, the nails. And the longer women are on plenty of estrogen, the better these things get over time. Their brains and bodies heal better and better and better month after month after month, really with a plateau of around 12 to 18 months for some women, 24 months, and even for some women beyond that, up to 5 years.
So what happens at the plateau? Do you fall off, or is that a maintenance then?
No, now you're in a place of hormonal. This is what hormonal balance truly is. And that's why I call this a true hormonal balance. This is the sweet spot that women are looking for that most doctors don't know how to do. They're
Mm.
too afraid and they don't have, there's very little training. And so they don't understand that this exists. And
Hmm.
this is my concern with the FDA. You know, they're not, I don't think they're going to be looking at this for many years to come because they haven't even, they're just at the point where, okay, estrogen doesn't cause cancer. So now let's give you these bioidentical second generation HRT. So now we feel comfortable doing that. But it's still a low dose protocol, keeping women estrogen hungry or estrogen starved.
Yeah.
But women who do get enough estrogen, it's a completely different experience where their brains are completely saturated so that they're not falling apart. And this is really what I wanted to share is you do have choices. You're not stuck with these low dose protocols. Women are not stuck with these low dose protocols like you and me have discovered that, my gosh, if I have enough of the right hormones, my brain and body are under the impression that I'm young and youthful, and this actually acts as the most potent longevity agent because when women are estrogen deficient, it shortens telomeres. And
Mm.
when women restore their estrogen, you'll see a lengthening of these telomeres. And there's great studies in the National Library of Medicine that talks about this. So this is a great protocol. A fourth generation HRT system is just brilliant when it comes to women who want to get to that hormone sweet spot and maintain that for life. And for example, I mean, I'm a 60-year-old woman who maintains a regular cycle. And with the hormones, if women with a uterus will need to maintain both estrogen and progesterone,
Hmm.
some women, after they've had a hysterectomy, have a harder time tolerating progesterone. But boy, they can certainly benefit from that estrogen, and they don't necessarily need to take progesterone. But we do recommend it to see if they can tolerate it because there are so many benefits of taking progesterone and estrogen together, dosed adequately together. So
Hmm.
that estrogen is the dominant female main sex hormone that allows progesterone to work as that complementary secondary calming hormone for women, because those two hormones are really designed to work like yin yang to create a woman in her optimal mental and physical health. And so you can see that I just get really passionate about this because I truly believe that this is the future, even though
Yeah,
we're
that's
back here
clear.
with estrogen doesn't cause cancer, let's remove the black box warning. But I don't think it will be long until women realize that these low dose therapies that they will now be prescribed happily from their doctors, they will stop working. And so I think women need to understand that they're not stuck in this second generation estrogen starvation mode. And
Well,
that's,
and it's really brilliant, and it's exciting.
I love it because one, I don't have a mental illness, and I haven't since I started doing this. No depression, no bipolar disorder, no endometriosis, no PMDD. I mean, when I say no mental illness, I'm really not joking. This isn't a lie. I mean, I was every luteal phase of most of my life came with thoughts of suicide.
Mm.
And it's just nice to live a life where not only do I not think about suicide, I'm like trying to build my life because I'm so excited about all that's to come. And I have to calculate my age and think, okay, can I get that done before I die? Because I feel capable and I know I can depend on myself. And estrogen really is the self reliance hormone for women. So,
Well,
yeah, I
we've
do.
done a whole webinar talking about estrogen and hormone replacement therapy and mental health.
Yeah.
And, I think that that's a really important subject. And we'll probably do another podcast episodes dedicated to that
Yeah.
because therapists need to know for their clients who are coming in with some of these complaints that they should have their hormones tested.
Estrogen is the number one antidepressant a woman can have. And if therapists understand this, they can get their patients on a good HRT system that addresses all the mental illness symptoms that are associated with hormone deficiencies so that they're working now with a patient whose brain is working, and that whatever conditions they have, they can know is not a hormonally related issue, and that if the patient still has things to deal with, but now it's easier for a clinician to work with the patient to get down to the root of what's going on in their life and to heal and repair and not have to deal with the everyday crazy every week that the patient's always complaining about, and you never really get the patient better because you're trying to fix the I can't how am I going to survive this next week until I see you again mentality like I had for years.
Mm, yeah. Marie, this has been just a super rich topic today. The 4 generations of HRT. Just to recap for our listeners, if they go searching for a doctor who practices, 4th generation HRT, they're not going to see that probably written anywhere. That's a categorization that you've come up with to help explain these different
Mm.
uh, protocols, and that one has built on the next. But there are in our lexicon the four generations of HRT. And really the idea is we're talking about hormone restoration through replacement.
Yeah, and that's the thing women need to look for. We want full restoration. We're not interested in low dose replacement. We want full restoration. So really, if you're a woman who's on HRT and you feel like that your hormone therapy is not working for you, or it's not working like it should, or it stopped working, or you're just ready to give me the right amount of the right hormones. I'm tired of jumping from one doctor to the next, like many women do, and spend thousands of dollars back in the same place where they started. I recommend visiting advancedhormonebalancing.com and booking a complimentary consultation, a discovery session with one of our clinical hormone coaches. And this is really the best way to find out if this advanced hormone replacement therapy protocol is a good fit for you. It's not for everybody, but it is for most, and it's extremely life-changing if it is. And leave a comment in the comments if this resonated with you, and share it with your friends and subscribe. And further, if there's something you want us to talk about on this podcast, go to menopausemoxie.com/podcast. At the bottom of that page, you'll find a form to fill out to let us know and give us some feedback. What do you want to hear us talk about here? And share this with your friends, because the more women understand that how much control they have over how their brains and bodies function, the better off they'll feel. And really, having a girlfriend with full hormone restoration is much different than interacting with her when she's estrogen deficient. So I really appreciate you spending your time with us today.
Thanks everyone for listening, and we'll see you next time.
Thank you. See you next time.